Welcome to Module 4 of NCLEX RN Review course. The topics that will be covered in this module will be the female reproductive structures, obstetric assessment, and the prenatal period. Let's look into the external genitalia of the female reproductive system. Mons veneris, they are hairy skin-covered pad of fat over symphysis pubis. Labia majora, they are hairy skin-covered folds. Labia minora are small inner folds covered with modified skin. Clitoris, they are a small mound of erectile tissue below the junction of the two labia minora. Urinary meatus is an opening into the urethra. It is posterior to clitoris and anterior to vagina. Skene's gland. They are small mucus glands and they have ducts on each side of the urinary meatus. Vaginal orifice is posterior to urinary meatus and opening into vagina. Bartholin glands are two small glands and they have ducts on each side of the vaginal orifice. Skene's gland and Bartholin glands are more prone to infection, especially gonococcal infections. Breasts or mammary glands. They are located under skin over pectoralis major. The size of the breast is associated with the deposits of adipose tissue and not the amount of glandular tissue, because glandular tissue is approximately same in all females. Let's look into the structure of the breast. Internal structure. It's divided into lobes and lobules. There are excretory duct that leads from each lobe to opening in the nipple. Externally, the breast consists of nipples and areola. Now, areola are circular pigmented area surrounding the nipples. What's the function of the breast? The main function of the breast is to secrete milk, lactation. Expulsion of placenta causes decrease in estrogens and progesterone that stimulates the anterior pituitary to increase the prolactin production. The prolactin stimulates the alveoli of the breast to secrete milk. Suckling controls lactation. It stimulates the posterior pituitary production of oxytocin, causing release of milk from the alveoli into ducts, and this is called the let-down reflex, enabling the removal of milk by suckling. Organs of the female reproductive system. The internal reproductive organs are vagina, uterus, cervix, uterine ligaments, fallopian tubes, ovaries. Ovaries or female gonads. They are located behind and below the fallopian tubes, anchored to uterus and broad ligaments. The size and shape of an ovary is equal to that of a large almond. At birth, it contains several 100,000 Graafian follicles that are embedded in connective tissue. Between menarche and menopause, one follicle matures each month, ruptures from the ovarian surface, and is expelled into the pelvic cavity that enters the fallopian tube. The main function of the ovaries are to form and expel the ova and to secrete estrogen and progesterone. Estrogen. It helps to stimulate the development of secondary sexual characteristics, that is, hair, breasts, and it helps in the thickening of the endometrium, accelerate protein anabolism, and stimulate long bone calcification. Progesterone. It prepares the endometrium for implantation of the fertilized ovum, inhibits uterine contraction during pregnancy, promotes development of alveoli of estrogen-primed breasts in preparation for lactation. Fallopian tubes. The fallopian tubes are attached to upper and outer angles of the uterus. The distal ends are fimbriated and open into the pelvic cavity. The mucosal lining of the tubes and the peritoneal lining of the pelvis are in direct contact. They are ducts through which ova travel from ovaries to the uterus, and it is also the location of fertilization. Uterus. Uterus is located in the pelvic cavity between the bladder and rectum. It is a muscular pear-shaped organ approximate the size of clenched fist. Uterus is divided into two main parts: corpus or body and cervix. Corpus is the upper main portion of the uterus. Fundus is the bulging upper area of the corpus. Cervix. It's a lower portion of the uterus. The internal os is adjacent to the uterus and the external os is adjacent to the vagina. Isthmus or the lower uterine segment separates the corpus from the cervix. Talking about the layers of uterus. There are three layers of the uterus. Endometrium, that's the innermost layer. Myometrium, that is the middle, muscular and the thickest layer. And perimetrium, that's the outer layer. Uterus is located over bladder in the pelvic cavity. The cervix joins the vagina. The ligaments, example, the broad ligaments, uterosacral ligaments, posterior ligament, anterior ligament, and the round ligaments maintain the position of the uterus. The main function of the uterus is menstruation, pregnancy, and labor. Cervix. The internal os of the cervix opens into the body of the uterine cavity. The cervical canal is located between the internal os and the external os, and the external cervical os opens into the vagina. Now, vagina is a muscular tube that extends from the cervix to the vaginal opening in the perineum. It is otherwise called as the birth canal. It is located between the rectum and the urethra. The vagina is a collapsible musculo-membranous tube that is capable of distension, and its outlet is to the exterior covered by hymen. Hymen is a fold of mucous membrane. The functions of vagina. It is a receptacle for semen. It's a lower portion of the birth canal. And it's an excretory duct for uterine secretions and menstrual flow. The male reproductive anatomy. The external genitals are penis and scrotum, and the internal reproductive organs are testis, epididymis, vas deferens, ejaculatory ducts, urethra, and accessory glands. Let's look into the male reproductive organs. Penis. The structures included in the penis are the body or the shaft, the glans penis, and the urethra. Penis is a pathway for urination and an organ for intercourse. Scrotum. The structures included in the scrotum are the testis, epididymis, and vas deferens. The temperature of the scrotum is slightly lower than that of the body temperature. Prostate glands. They secrete milky alkaline fluid that enhances sperm movement. It also helps to neutralize the acidic vaginal secretions. What do you understand by menstrual cycle? Menstrual cycle is a periodic vaginal bleeding related to changes in the uterus and the ovaries, and it is cyclical from the time of menarche to menopause. The length of the cycle is measured from the onset of the uterine bleeding to the onset of the next period of bleeding. The mean cycle length is 25 days and the range is from 21 to 45 days. It is regulated by hormonal communication between the hypothalamus and pituitary and ovaries and uterine endometrium. During each cycle, several follicles begin maturation process, and usually one reaches full maturity, expels its ovum, which enters a fallopian tube, and this is the ovarian activity. So there are two phases in the menstrual cycle: the ovarian changes and the endometrial changes. Let's look into each one of them. So now let's understand the ovarian changes of the menstrual cycle. The ovarian changes are divided into two phases, that is the pre-ovulatory phase and the luteal phase. In the pre-ovulatory phase, the hypothalamus releases gonadotropin releasing hormone through the portal system to the anterior pituitary system. The secretion of the follicle stimulating hormone by the anterior lobe of the pituitary gland stimulates growth of the follicles. Most follicles die, leaving one to mature into a large Graafian follicle. The estrogen produced by the follicle stimulates increased secretion of luteinizing hormone or LH by the anterior lobe of the pituitary gland. The follicle ruptures and releases an ovum into the peritoneal cavity. The next phase is a luteal phase. This phase begins with ovulation. The body temperature decreases and then increases by 0.5 degrees Fahrenheit to 1 degree Fahrenheit around the time of ovulation. Corpus luteum is formed from the follicle cells that remain in the ovary after ovulation, and it secretes estrogen and progesterone during the remaining 14 days of the cycle. The corpus luteum degenerates if the ovum is not fertilized, and the secretion of estrogen and progesterone declines. The decline of estrogen and progesterone stimulates the anterior pituitary to secrete more of FSH and LH, initiating a new reproductive cycle. Now let's understand the uterine changes of the menstrual cycle. It is divided into three phases: the menstrual phase, the proliferative phase, and the secretory phase. The menstrual phase lasts for 4 to 6 days of bleeding as the endometrium breaks down because of decreased levels of estrogen and progesterone, and at the same time the level of FSH increases, enabling the beginning of a new cycle. Proliferative phase. It lasts for 9 days, where the estrogen stimulates the proliferation and growth of the endometrium. As the estrogen level increases, it suppresses the secretion of FSH and increases the secretion of luteinizing hormone, and this stimulates ovulation and the development of corpus luteum. Ovulation occurs between the 12th and the 16th day of the menstrual cycle. The estrogen level is high and the progesterone level is low. The last is the secretory phase that lasts for about 12 days and follows ovulation. This phase is initiated in response to the increase in the luteinizing hormone level. The Graafian follicle is replaced by the corpus luteum, and it secretes progesterone and estrogen. Progesterone prepares the endometrium for pregnancy if a fertilized ovum is implanted. This is about the menstrual cycle. So now let's know the female pelvis and measurements. The female pelvis is divided into two parts: the true pelvis and the false pelvis. The true pelvis lies below the pelvic brim, and it consists of the pelvic inlet, the mid-pelvis, and the pelvic outlet. The false pelvis is the shallow portion above the pelvic brim, and it supports the abdominal viscera. So as you can see in this slide, this portion is the true pelvis, which involves the pelvic brim or the inlet, the mid-pelvis, this is the mid-pelvis, and the pelvic outlet. So this portion is the true pelvis, and here this is the false pelvis that is not involved in labor. This slide will give you the clear picture of the true pelvis and the false pelvis. So the true pelvis involves the pelvic inlet, the mid-pelvis, and the pelvic outlet. So now let's understand the types of pelvis. They are gynecoid pelvis, anthropoid pelvis, android pelvis, and platyploid pelvis. Gynecoid pelvis, it's a normal female pelvis that is transversely rounded or blunt, and it is most favorable for successful labor and birth. Anthropoid pelvis are oval in shape with adequate outlet but with a narrow pubic arch. Android pelvis resembles a male pelvis that's heart-shaped or angulated, and it is not favorable for labor or delivery because it has narrow pelvic planes that can cause slow descent and mid-pelvic arrest. Platyploid pelvis is flat with an oval inlet and has wide transverse diameter but short anterior-posterior diameter, making the labor and birth difficult. So these are the types of pelvis: the gynecoid pelvis, android pelvis, anthropoid pelvis, and platyploid pelvis. As discussed in the previous slide, the gynecoid pelvis is the most favorable for success of labor and birth. Now let's know the pelvic inlet diameters, the pelvic midplane diameters, and the pelvic outlet diameters. The pelvic inlet diameters includes the anterior posterior diameter, the transverse diameter, the oblique or diagonal diameter, and the posterior sagittal diameter. The pelvic or midplane diameter is a transverse diameter, and that's the largest plane and the longest diameter. Then the pelvic outlet diameters are the transverse or intertuberous diameter, and the outlet presents the smallest plane of the pelvic canal. The pelvic inlet diameters, as I mentioned earlier, it includes the anterior posterior diameter, which is the diagonal conjugate, the true conjugate, and the obstetric conjugate. The transverse diameter is the largest of the pelvic inlet diameters, located at the right angles to the true conjugate. The oblique or the diagonal diameter is not clinically measurable, and the posterior sagittal diameter is a distance from the point where the anterior, posterior, and the transverse diameter cross each other to the middle of the sacral promontory. So here you can view the pelvic inlet diameters, the pelvic midplane diameters, and the pelvic outlet diameters. So in this slide and the next slide, you can find the explanation about the diameters. Moving on to our next topic, fertilization and implantation. The fertilization occurs in the ampulla of the fallopian tube when the sperm and the ovum unite. When fertilized, the membrane of the ovum undergoes changes that prevent entry of another sperm. Each reproductive cell carries 23 chromosomes. The sperm carry an X or a Y chromosome, XY for male and XX females. Implantation. The zygote is propelled toward the uterus and implants 6 to 8 days after ovulation. The blastocyst secretes chorionic gonadotrophin hormone to ensure that the corpus luteum remains viable, and secretes estrogen and progesterone for the first 2 months of gestation. So now let's know the fetal development and fetal environment. The fetal development, as you can see, is divided into 3 periods. The pre-embryonic period, that's the first 2 weeks after conception. The embryonic period begins on the day 15th through approximately the 8th week after conception, and the fetal period begins at the 9th week after conception and ends with birth. Fetal environment. Amnion. It encloses the amniotic cavity. It is an inner membrane that forms about the 2nd week of the embryonic development. It forms a fluid-filled sac that surrounds the embryo and later the fetus. Chorion. It is the outer membrane enclosing the amniotic cavity. It becomes vascularized and forms the fetal part of the placenta. Amniotic fluid. The amniotic fluid is about 800 ml and reaches to 1200 ml by the end of pregnancy. The amniotic fluid surrounds, cushions and protects the fetus and allows for fetal movement. It also helps to maintain the body temperature of the fetus. It contains fetal urine and is a measure of the fetal kidney function. The fetus modifies the amniotic fluid through the process of swallowing, urinating, and the movement of fluid through the respiratory tract. So now let's understand the placenta and its functions. The placenta provides for exchange of nutrients and waste products between the fetus and the mother. The placenta begins to form at implantation and the structure is complete by the 12th week. It produces hormones to maintain pregnancy and assumes full responsibility for the production of these hormones by the 12th week of gestation. In the 3rd trimester, transfer of maternal immunoglobulin provides a fetus with passive immunity to certain diseases for the first few months after birth. By 10th to 12th week, genetic testing can be done via chorionic villus sampling or CVS. Large particles such as bacteria cannot pass through the placenta, but nutrients, drugs, alcohol, antibodies, and viruses can pass through the placenta. This slide explains about the normal fetal growth development pertaining to the weeks. I would suggest you to look into the slide and make your own notes on the same.
Let's understand fetal circulation. Umbilical cord. It carries two arteries and one vein. The arteries carries deoxygenated blood and the waste products from the fetus. The veins carry oxygenated blood and provides oxygen and nutrients to the fetus. The fetal heart rate depends on the gestational age. The fetal heart rate is 160 to 170 beats per minute in the first trimester, but slows with fetal growth to 110 to 160 beats per minute near or at term. The fetal heart rate is about twice the maternal heart rate. Fetal circulation bypass. Fetal circulation bypass is present because of the non-functioning lungs. Bypasses must close after birth to allow blood to flow through the lungs and the liver. The ductus arteriosus connects the pulmonary artery to the aorta, bypassing the lungs. The ductus venosus connects the umbilical vein and the inferior vena cava, bypassing the liver. And the foramen valve is the opening between the right and the left atria of the heart, bypassing the lungs. So here you will find a video showing the fetal circulation. And this is the explanation of the fetal circulation. So I would recommend you to take on the notes. Family planning. It involves choosing when to have children. It includes contraception, prevention of pregnancy, and methods to achieve pregnancy. Contraceptive agents prevent pregnancy by inhibiting the gonadotropin production, affecting both pituitary and hypothalamic centers. The progesterone agents suppresses the LH production, and estrogenic agents suppresses FSH production. Synthetic preparations of estrogen-like and/or progesterone-like compounds are contained in oral, transdermal, vaginal, and parenteral contraceptive agents and some intrauterine devices. Birth control. The focus of counseling on contraception must meet the needs and feelings of the woman and her partner. Several factors should be considered when choosing a method of birth control, including effectiveness, safety, and personal preferences. The woman's preferences are most important, and the cultural practices and beliefs and religious or other personal beliefs may affect the choice of contraception. Other factors that bear on selection of a contraceptive method include family planning goals, age, frequency of intercourse, and the individual capacity for compliance. If family planning goals have already been met, sterilization of either the male or female partner may be desirable. For women who frequently engage in coitus, oral contraceptives or a long-term method such as implants or an intrauterine device IUD may be considered. When sexual activity is limited, use of spermicide, condoms, or a diaphragm may be most appropriate. Because some methods have adverse effects, a signed informed consent form may be needed. Infertility. It is the involuntary inability to conceive when desired. Some factors contributing to infertility in men include abnormalities of sperm, abnormal erections or ejaculations, abnormalities of the seminal fluid. Some factors that contribute to infertility in women include disorders of ovulation or abnormalities of the fallopian tubes or cervix. Several diagnostic tests are available to determine the possible cause of infertility, and the therapy recommended may depend on the cause of the infertility. Infertility options. Options include medications, surgical procedures, and the therapeutic insemination. Other therapies are available, such as in vitro fertilization, surrogate mother, and embryo hosts. Adoption may also be an option. The nurse needs to provide support to the couple in the decision-making process and during therapy. Let's discuss about the second topic included in this module, that is obstetrical assessment. The gestation is the time from fertilization of the ovum until the estimated date of confinement or estimated date of delivery. That's about 280 days. Now, Nagel's rule is used for estimating the date of confinement. Use of Naegele's rule requires that the women have a regular 28-day menstrual cycle. Subtract 3 months and add 7 days to the first day of the last menstrual period, then add 1 year. Alternatively, add 7 days to the last menstrual period and count forward the 9 months. This will give you the estimated date of delivery. So here's an example. If the first date of the last menstrual period was September 12, 2014, subtract 3 months. So it will be June 12, 2014. Add 7 days, that will be June 19, 2014, and add 1 year. So the expected date of confinement or delivery would be June 19, 2015.
Let's understand certain terms before we continue. Gravida. It refers to a pregnant woman, and gravidity refers to the number of pregnancies. A nulli gravida is a woman who has never been pregnant. A primi gravida is a woman who is pregnant for the first time. A multigravida is a woman in at least her second pregnancy. What do you mean by parity? Parity is a number of births. Please understand, it is not the number of fetuses, example twins. It is a number of births carried past 20 weeks of gestation, whether or not the fetus was born alive. A nullipara woman is a woman who has not had a birth at more than 20 weeks of gestation. A primipara is a woman who has had one birth that occurred after the 20th week of gestation. And a multipara is a woman who has had 2 or more pregnancies to the stage of fetal viability. Use of GTPAL, that is GTPAL. GT is gravidity, the number of pregnancies including the present one. T is the term births, the number born at term, that is longer than 37 weeks of gestation. P is the preterm births, the number born before 37 weeks of gestation. A stands for abortion or miscarriages, the number of abortions or miscarriages. A termination of pregnancy after 20 weeks of gestation is referred to as therapeutic termination. L is the number of current living children. What are the signs of pregnancy? They are the presumptive signs, probable signs, and the positive signs. What are the presumptive signs? They include amenorrhea, nausea and vomiting, increased size and increased feeling of fullness in the breasts, pronounced nipples, urinary frequency, quickening, that is the first perception of the fetal movement by the mother, may occur in the 16th to the 20th week of gestation. There could be fatigue and discoloration of the vaginal mucosa. The probable signs of pregnancy include uterine enlargement, Hager's sign, that is compressibility and softening of the lower uterine segment that occurs at about 6 weeks. Then Godel's sign, that is a softening of the cervix that occurs at the beginning of the second month. Chadwick's sign. It's a violet coloration of the mucous membranes of the cervix, vagina and vulva that occurs at about week 4. Ballottement. It is a rebounding of the fetus against the examiner's fingers on palpation. Braxton Hicks contractions are irregular painless contractions that may occur intermittently throughout pregnancy. And positive pregnancy tests for determination of presence of human chorionic gonadotrophin. Now, positive signs or the diagnostic signs of pregnancy include the fetal heart rate detected by electronic device, that is a Doppler transducer, at 10 to 12 weeks, and by non-electronic device, that's a fetoscope, at about 20 weeks of gestation. Active fetal movements palpable by the examiner, or outline of the fetus via radiography or ultrasonography are the diagnostic or positive signs of pregnancy. How do we measure the fundal height? Place the client in a supine position. Place the end of the tape measure at the level of the symphysis pubis and stretch the tape to the top of the uterine fundus. Note and record the measurement. The fundal height is measured to evaluate the gestational age of the fetus. During the second and third trimesters, that is from week 18 to 30, fundal height in centimeters approximately equals the fetal age in weeks, that is plus or minus 2 centimeter. At 16 weeks, the fundus can be found approximately halfway between the symphysis pubis and the umbilicus. At 20 to 22 weeks, the fundus is approximately at the location of the umbilicus. And at 36 weeks, the fundus is at the xiphoid process. When assessing the fundal height, monitor the client closely for supine hypotension when placed in supine position. So now this picture refers to the fundal height by weeks of normal gestation with a single fetus. Now let's discuss certain maternal risk factors. Maternal age. Women younger than 20 years and older than 35 years are at the risk for adverse perinatal outcomes. Adolescent pregnancies. Factors that result in adolescent pregnancy include the early onset of menarche, changing sexual behaviors in this age group, problems with family relationships, poverty, and lack of reproduction and birth control. The major concerns related to adolescent pregnancy include poor nutritional status, emotional and behavior difficulties, lack of support system, increased risk of stillbirth, low birth weight infants, fetal mortality, cephalopelvic disproportion, and increased risk of maternal complications such as hypertension, anemia, prolonged labor, and infections. So, the role of the nurse in reducing the risks and consequences of adolescent pregnancies is twofold. First, to encourage early and continued prenatal care, and second, to refer the adolescent if necessary for appropriate assistance, which can help counter the effects of negative socio-economic environment. Genetic considerations. Genetic abnormalities such as defective genes or transmissible inherited disorders can result in congenital anomalies. So the nurse should perform a genetic risk assessment to determine an inherited risk. Healthcare. Failure to seek and obtain prenatal care, including dental care, increases the risk for preterm birth and low birth weight. Abuse and violence. Physical abuse and violence can increase the risk for abruptio placentae, preterm birth, and infections from unwanted and forced sex. Medical conditions. Concurrent medical conditions such as but not limited to diabetes mellitus, hypertensive disorders, or cardiac diseases increase the risk of pregnancy. German measles or rubella. Maternal infection during the first 8 weeks of gestation carries the highest rate of fetal infection. Adequate nutrition is necessary for normal fetal growth and development. Women of childbearing age should take folic acid supplements to prevent neural tube defects and orofacial clefts in the fetus. Maternal risk factors related to sexually transmitted infections. Syphilis. In syphilis, the organism can cross the placenta, thereby leading to spontaneous abortions and increasing the incidence of mental subnormality and physical deformities. Condyloma acuminatum or human papilloma virus. The transmission may occur during vaginal birth, and the infection is associated with the development of epithelial tumors of the mucous membranes of the larynx in children. Gonorrheal infections. The fetus is contaminated at the time of delivery. Maternal infection may result in the postpartum infection of the neonate and puts the neonate at risks for ophthalmia neonatum, pneumonia and sepsis. Chlamydal infections. The transmission may also occur during vaginal birth and can result in neonatal conjunctivitis or pneumonitis. The infection can also cause premature rupture of the membranes, premature labor, and postpartum endometritis. Trichomoniasis. It is associated with the premature rupture of membranes and the postpartum endometritis. Genital herpes simplex virus. These are characterized by painful lesions, fever, chills, malaise, and severe dysuria and may last 2 to 3 weeks. The assessment includes questioning all women about symptoms and inspecting the vulval, perineal, and vaginal areas for vesicles or areas of ulceration or crusting. This is done during pregnancy and at the onset of labor. Vaginal birth may be acceptable, but cesarean birth is recommended if visible lesions are present. Infants who are born through an infected vagina should be carefully observed and samples should be taken for culture. Human immunodeficiency virus or HIV infection. HIV is transmitted through blood, blood products, and other bodily fluids such as urine, semen, and vaginal secretions. The virus is also transmitted through exposure to infected secretions during birth and through breast milk. Repeated exposure to the virus during pregnancy through unsafe sex practices or intravenous drug use can increase the risk of transmission to the fetus. Perinatal administration of zidovudine may be recommended to decrease the risk of transmission of HIV from mother to fetus. Substance abuse. Substance abuse threatens normal fetal growth and successful term completion of the pregnancy. Substance abuse places the pregnancy at risk for fetal growth restriction, abruptio placentae, and fetal bradycardia. Many substances crosses the placenta and can be teratogenic, like certain drugs, tobacco, alcohol, and no over-the-counter medications should be taken unless prescribed by the healthcare provider. Smoking can result in low birth weight and a higher incidence of birth defects and stillbirths. Physical signs of drug abuse may include dilated or contracted pupils, fatigue, track or needle marks, skin abscesses, inflamed nasal mucosa, and inappropriate behavior by the mother. Consumption of alcohol during pregnancy may lead to fetal alcohol syndrome and can cause jitteriness, physical abnormalities, and congenital abnormalities, and growth deficits in the newborn. Let's understand certain physical, physiological, and emotional changes that takes place during pregnancy. So beginning with the physiological maternal changes. Let's begin with the cardiovascular changes. The circulating blood volume increases, plasma increases, and the total red blood cell volume also increases from approximately 40 to 50%. Physiological anemia occurs as the plasma increases. It exceeds the increase in the production of the red blood cells. Iron requirements are increased. Heart size increases and it is elevated slightly upward and to the left because of the displacement of the diaphragm as the uterus enlarges. Retention of sodium and water may also occur. Let's understand the changes in the gastrointestinal system. Nausea and vomiting may occur as a result of the secretion of human chorionic gonadotrophin hormone, and it subsides by the 3rd month. The women may complain of poor appetite, that is because of decreased gastric motility and alterations in taste and smell. Constipation is more evident because of an increase in the progesterone production or pressure of the uterus, resulting in decreased gastrointestinal motility. The women may complain of flatulence and heartburn because of decreased gastrointestinal motility and slowed emptying of the stomach caused by an increase in the progesterone production. Hemorrhoids is more common because of increased venous pressure. Gum tissue may become swollen and easily bleed because of increasing levels of estrogen. There is an excessive secretion of saliva, otherwise called ptylism. That's because of increased levels of estrogen. Understanding the changes in the renal system. The frequency of urination increases in the 1st and 3rd trimesters because of the increased bladder sensitivity and the pressure of the enlarging uterus on the bladder. There is decreased bladder tone and it is caused by an increase in the progesterone and the estrogen levels. The bladder capacity increases in response to increasing levels of progesterone, and the renal threshold for glucose is reduced. In the endocrine system, the basal metabolic rate and the metabolic function increases. The anterior lobe of the pituitary gland enlarges, the thyroid gland enlarges slightly, and there is increase in the thyroid activity. The parathyroid increases in size and there is increased production of aldosterone. The body weight increases and there is water retention, which can again contribute to the weight gain. In the musculoskeletal system, the changes in the center of gravity begin in the 2nd trimester and are caused by the hormones relaxin and progesterone. The lumbosacral curve increases. Aching, numbness, and weakness may result. The walking becomes more difficult and the women may develop a waddling gait and is at a risk for falls. Relaxation and increased mobility of the pelvic joint occurs, which permit enlargement of the pelvic dimensions. The abdominal wall stretches with loss of tone throughout pregnancy, and this is regained in the postpartum period. Umbilicus flattens or protrudes. During pregnancy, postural changes occur as the increased weight of the uterus causes a forward pull of the bony pelvis. So it is important for the nurse to encourage the client to implement measures that maintain safety and correct posture to prevent a backache. Understanding the physiological changes in the reproductive system. The uterus enlarges, increasing in mass from approximately 60 to 1000 grams, as a result of hyperplasia and hypertrophy. The uterus becomes highly vascularized with increase in the number of blood vessels and the lymphatics. Irregular contractions can occur. The cervix becomes shorter, more elastic and larger in diameter. The endocervical glands secrete a thick mucus plug, which is expelled from the canal when dilation begins. There is increased vascularization and an increase in the estrogen cause softening and a violet discoloration known as Chadwick's sign, which occurs at 4 weeks of gestation. The major function of ovary is to secrete progesterone for the first 6 to 7 weeks of pregnancy. The maturation of the new follicles is blocked and the ovary cease ovum production. Hypertrophy and thickening of the muscles of the vagina are observed, and there is increase in the vaginal secretions, and the secretions are usually thick, white and acidic. Breast changes occurs because of the increasing effects of estrogen and progesterone. The breast size increases and the breast may become tender. The nipples may become more pronounced, the areola become darker in color, and the superficial veins become prominent. There is hypertrophy of the Montgomery's follicles, and the colostrum may leak from the breast. Some changes in the skin occurs because of the levels of the melanocyte stimulating hormone is increased due to the increase in the estrogen and the progesterone levels. So there is increased pigmentation of the skin, dark streak down the midline of the abdomen, that is called as linea nigra. Chloasma, or the mask of pregnancy, it is a blotchy brownish hyperpigmentation over the forehead, cheeks and nose. Reddish purple stretch marks or striae are observed on the abdomen, breast, thighs and upper arms. Vascular spider nevi may occur on the neck, chest, face, arms and legs. The rate of hair growth may also increase. In the respiratory system, the oxygen consumption increases by approximately 15% to 20%. The diaphragm is elevated because of the enlarged uterus, and the women may experience shortness of breath. During pregnancy, a woman's pulse rate may increase about 10 to 15 beats per minute. The blood pressure slightly decreases in the second trimester, and the respiratory rate remains unchanged or slightly increased.
Now let's know certain psychological maternal changes that may take place during pregnancy. Ambivalence. It occurs early in pregnancy and even when the pregnancy is planned. The mother may experience a dependence-independence conflict, and the ambivalence is related to the role changes. The partner may also experience ambivalence, and it could be related to the new role that he is assuming, increased financial responsibilities, and sharing the wife's attention with the child. The factors that may be related to acceptance of the pregnancy are the woman's readiness for the experience and her identification with the motherhood role. Emotional liability may be manifested by frequent changes of the emotional states or extremes in emotional states. And these emotional changes are common, but the mother may think that these changes are abnormal. Body image changes. The changes in a woman's perception of her image during pregnancy occur gradually and may be positive or negative. The physical changes and symptoms that the woman experiences during pregnancy contribute to her body image. The woman may daydream to prepare for motherhood and think about the maternal qualities that she would like to possess. The woman first accepts the biological fact that she is pregnant, and next accepts the growing fetus as distinct from herself and a person to nurture. And finally, the woman prepares realistically for the birth and parenting of the child.
Let's talk about the discomforts of pregnancy. Nausea and vomiting, occurring in the first trimester and subsides by the third month. It is caused by the elevated levels of human chorionic gonadotrophin and changes in the carbohydrate metabolism. So the interventions are eating dry crackers before arising, avoiding brushing teeth immediately after arising, eating small, frequent, low-fat meals during the day and drinking liquids between meals rather than at meals, and avoiding fried and spicy foods. Syncope is usually seen in the first trimester and may be triggered hormonally or caused by the increased blood volume, anemia, fatigue, sudden position changes, or lying supine. So the interventions are sitting with the feet elevated and teach to change positions slowly, otherwise the patient is at risk of falls. So the nurses needs to instruct the pregnant women to avoid lying in supine position, particularly in the second and third trimester. The supine position places the women at risk for supine hypertension, which occurs as a result of the pressure of the uterus on the inferior vena cava. Urinary urgency and frequency occurs in the first and third trimester mainly due to the pressure of the uterus on the bladder. Encourage the pregnant women to take 2000 ml of fluid during the day and limiting the fluid intake in the evening. Voiding at regular intervals, sleeping sideline at night, and performing Kegel's exercise. Breast tenderness. It occurs in the first through the third trimesters and is caused by increasing levels of estrogen and progesterone. So the interventions are wearing a supportive bra, avoiding the use of a soap on nipples and areola to prevent from drying. Increased vaginal secretions are mainly caused by the hypertrophy and thickening of the vaginal mucosa and increased mucus production, and it occurs from the first throughout the pregnancy. So the interventions are using proper cleansing and hygienic techniques, wearing cotton underwear, avoiding douching, and consulting a health care provider if infection is suspected. Nasal stuffiness results from increased estrogen, which causes swelling of the nasal tissues and dryness. So encourage the use of a humidifier and avoid the use of nasal sprays or antihistamines. Fatigue usually results from hormonal changes and it occurs in the first and third trimester. So arrange frequent rest periods throughout the day using correct posture and body mechanics, obtaining regular exercise, performing muscle relaxation and strengthening exercise for the leg and hip joints, and avoiding eating and drinking foods containing stimulants throughout the pregnancy. Heartburn occurs in the second and third trimesters due to the increased progesterone levels, decreased gastrointestinal motility, esophageal reflux, and displacement of the stomach by the enlarging uterus. So the interventions include eating small, frequent meals, sitting upright for 30 minutes after a meal, drinking milk between meals, avoiding fatty and spicy foods, and consulting a health care provider for the use of an antacid. Ankle edema occurs due to vasodilation, venous stasis, and increased pressure below the uterus, mainly seen in the second and the third trimester. Interventions are elevating the leg at least twice a day and when resting, sleeping in a side-lying position, wearing supportive stockings or supporting hose, and avoiding sitting or standing in one position for longer periods. Varicose veins results from weakening walls of the veins or valves and venous congestion, mainly seen in the second and third trimester. So the interventions include wearing supportive stockings or support hose, elevating the feet when sitting, lying with the feet and hips elevated, avoiding long periods of standing or sitting, avoiding leg crossing, moving about while standing to improve the circulation, and avoiding constrictive articles of clothing such as knee-high stockings. Thrombophlebitis is rare, but it may occur, so teach leg exercise and avoid airline travel. Headache usually occurs in the second and third trimesters, resulting from the changes in the blood volume as vascular tone. So the interventions are changing position slowly, applying a cool cloth to the forehead, eating small snack, and using acetaminophen only if prescribed by the healthcare provider. Hemorrhoids results from increased venous pressure and constipation, usually occurring at the second and third trimester of pregnancy. The interventions are soaking in a warm sitz bath, sitting on a soft pillow, eating high fiber foods and drinking sufficient fluids to avoid constipation. Increase exercise such as walking and applying ointments, suppositories or compresses as prescribed by the healthcare provider. Constipation results from an increase in the progesterone production, decreased intestinal motility, displacement of the intestines, pressure of the uterus and taking iron supplements. The interventions are eating high fiber foods such as whole grains, fruits and vegetables and drinking no less than 2000 ml per day. Exercising regularly such as a daily 20-minute walk and consulting a healthcare provider about interventions such as stool softeners, laxatives or enemas. Backache is caused by an exaggerated lumbosacral curve resulting from an enlarged uterus, mainly seen in the second and third trimester of pregnancy. So encourage the pregnant women to move about slowly, obtaining rest, using correct posture and body mechanics, wearing low-heeled, comfortable and supportive shoes. Encourage the pregnant women to perform pelvic tilt or rock exercises and conscious relaxation exercises. Leg cramps. It results from an altered calcium-phosphorus balance and pressure of the uterus on nerves or from fatigue. Occurs mainly at the second and third trimesters. So the interventions include getting regular exercise, especially walking, dorsiflexing the foot of the affected leg and increasing calcium intake. Lastly, shortness of breath. It results from the pressure on the diaphragm from the enlarged uterus and occurs mainly at the second and third trimester of pregnancy. Interventions are taking frequent rest periods, sitting and sleeping with the head of the bed elevated or on the side, and avoiding overexertion. These are the common pregnancy discomforts as mentioned earlier and the interventions to deal with them. So now let's look into certain antepartum diagnostic testings. The usual schedule for antepartum health care visit is every 4 weeks for the first 28 to 32 weeks, every 2 weeks from 32 to 36 weeks, and every week from 36 to 40 weeks. Certain diagnostic testings are blood type and Rh factor, rubella titer, hemoglobin and hematocrit levels, the pap smear, sexually transmitted infection screening, sickle cell screening, tubercle skin tests, hepatitis B surface antigens, urine analysis and urine culture, ultrasonography. Other tests are biophysical profile, Doppler blood flow analysis, percutaneous umbilical cord sampling, alpha-fetoprotein screening, chorionic villus sampling, amniocentesis, kick counts, Fern's test, nitrogen test, fibronectin test, non-stress test, and contraction stress test. Next, we will look on to the maternal nutrition. The average expected weight gain during pregnancy is 25 to 35 pounds for women with a normal pre-pregnancy weight. And in the slide, you can see weight gain ranges for underweight women, overweight women, obese women. An increase of about 300 calories per day is needed during pregnancy. Calorie needs are greater in the last 2 trimesters than in the first. And an increase of about 500 calories per day is needed during lactation. A diet high in folic acid and folic acid supplements are recommended, and it is necessary for the women of all childbearing age to prevent neural tube defects and orofacial clefts in the fetus. At least 8 to 10 glasses of fluid are needed each day, of which 4 to 6 glasses should be water. Sodium is not restricted unless specifically prescribed by the healthcare provider. An increase of about 300 calories per day is needed during pregnancy. No extra daily calorie is required in the first trimester, 340 calories in the second trimester, and 452 calories in the third trimester. So there is increased maternal nutritional requirements for carbohydrates, proteins, fats, minerals, and iron supplements, and the mothers should be educated regarding iron-rich foods. Educate the mothers regarding the intake of fat-soluble vitamins and water-soluble vitamins and fluids. Fat-soluble vitamins are vitamin A, D, and K. And water-soluble vitamins are vitamin C, B complex, and folic acid, that is 0.4 mg daily, for the prevention of neural tube defects. Let's talk about the nutritional status assessment. The nutritional deficits should be assessed at the time of conception and during the early prenatal period. Maternal age is very important, especially in adolescent pregnancies. An expectant adolescent must meet her own growth needs in addition to the nutritional needs of pregnancy. Assess for the number of pregnancies and the interval between each pregnancies. Check for any physical, cultural, economic, and psychological needs. Lactose consumed by the individual with lactose intolerance can cause abdominal distension, discomfort, nausea, vomiting, cramps, and loose stools. So clients with lactose intolerance need to incorporate sources of calcium other than dairy products into their dietary patterns regularly. Milk may be tolerated in cooked forms, such as in custards or fermented dairy products, and cheese and yogurt are sometimes tolerated. Lactase, an enzyme, may be prescribed and is taken before ingesting milk or milk products. Lactase-treated milk or lactase-free products are also available commercially. Pica. It refers to eating non-food substances such as dirt, clay, starch, and freezer frost. The cause is unknown. Cultural values such as beliefs regarding the effect of a material on mother or fetus may make pica a common practice. Iron deficiency anemia can also occur as a result of pica. So here we end with the module 4 of the NCLEX RN review course. Thank you.